Welcome back to the deep dive. Anyone studying for, say, a critical care exam, or really just trying to get a grip on how the body stays balanced,
Mm.
knows the endocrine system can feel like, well, a bit of a maze. All those acronyms, the feedback loops, it definitely can be. And today, we're zeroing in on two glands that are like the master controllers, the pituitary and the adrenals.
Right.
And when they go off kilter, it throws everything else into chaos pretty much instantly.
And that chaos, that's actually our main theme today. It all really centers around a massive disruption in fluid and electrolyte balance. That's the core concept driving this chapter. When these glands aren't working right, the physical effects, even the psychological ones, they're severe. So our goal here is to break down the key pathophysiology, what these conditions look like, and the absolutely critical nursing priorities. You'll see other concepts like cellular regulation and immunity involved too, but fluids, that's the immediate, acute problem.
Got it. Okay, let's start at the top. In the brain, the pituitary gland. First up, hypopituitarism. It's a pituitary deficiency. There are a lot of hormones involved here. Which ones are the most dangerous if they're deficient?
Yeah, good question. The source really highlights two, ACTH, that's adrenocorticotropic hormone, and TSH, thyroid stimulating hormone. Those are the big ones, the most life-threatening if they're missing.
And why those two specifically?
Well, think of them as crucial messengers. ACTH signals the adrenal cortex to produce cortisol and aldosterone. TSH tells the thyroid gland what to do. If those signals aren't sent, the production of those vital hormones just stops or plummets, and that leads to really severe problems downstream.
Okay, that makes sense. So while lacking gonadotropins like LH and FSH definitely impacts sexual function, sterility, impotence in men, maybe amenorrhea women, loss of body hair, it's not quite the same immediate life or death situation.
Exactly. It causes significant changes, but not that acute crisis potential. We also see growth hormone deficiency in adults is a bit different. It messes with cellular regulation over time and increases bone breakdown. So you get thinner bones, osteoporosis, and a much higher risk for fractures later on. More of a chronic issue.
And since the pituitary isn't going to magically fix itself, the treatment involves hormone replacement therapy, HRT.
Often lifelong. Right?
Lifelong, yeah. And that brings its own set of considerations, especially with the sex hormones.
What should we watch out for?
Well, for men getting testosterone replacement, they take it until virilization occurs. That's the development of male secondary sex characteristics. But you need to monitor for side effects like acne, maybe baldness, and importantly, gynecomastia.
Male breast tissue development. Right. And for women on estrogen and progesterone, there's a big safety alert about cardiovascular risks, specifically hypertension and thrombosis, blood clots. And that risk really shoots up if the patient smokes.
Huge patient teaching point there. Okay, let's flip it. What about hyperpituitarism? Too much secretion, what usually causes that? Most often it's a pituitary adenoma, a benign tumor, usually in the anterior part of the gland. And these tumors tend to overproduce specific hormones, commonly prolactin, ACTH, or the one that causes the most visible changes, growth hormone, GH. And too much GH in an adult leads to acromegaly. What's notable about how that condition progresses?
It's the slowness of it. It's really insidious. The changes like thickened lips, coarser facial features, hands and feet getting bigger so rings and shoes don't fit. They happen so gradually.
So the person might not even realize for years.
Exactly. And in key point here, treatment can help reverse some of the soft tissue changes, but the skeletal changes, the enlarged bones in the skull, hands, feet, those are permanent.
Wow. Okay, so how do you diagnose it? The text mentions a specific glucose suppression test. How does that work?
Right. So normally if you give someone a big load of glucose, like 100 grams orally, their growth hormone levels should drop. The body basically says, okay, we've got plenty of fuel, no need for more growth signals right now.
Makes sense.
But in hyperpituitarism, that tumor making the GH, it doesn't listen to the glucose signal. So if you give the glucose and the GH level doesn't fall below 5 nanograms per milliliter, that strongly suggests hyperpituitarism. The tumor's just running wild.
And the treatment often involves surgery, right? A hypophysectomy to remove the tumor. Let's talk about nursing care there, because increased intracranial pressure, ICP, is a huge concern, absolutely critical. Pre-op teaching is all about preventing spikes in ICP. You have to tell the patient very clearly, don't brush your teeth vigorously, don't cough, don't sneeze, don't blow your nose, and definitely don't bend forward at the waist, anything that causes straining.
Exactly. All those things can jack up the pressure inside the head, which could mess up healing or worse, cause a CSF leak.
Cerebrospinal fluid leak. And post-op, if you see nasal drainage, you need to look for something specific.
Yes, the halo sign. You look at the drainage on the dressing. If it's clear fluid but has this light yellowish ring like a halo around the edge, that's highly suggestive of CSF.
And that's an emergency.
Immediate intervention needed. Big risk of meningitis or other complications. Post-op, we're also doing hourly neurochecks, watching fluid balance like a hawk. If urine output suddenly way exceeds intake, that could mean DI, diabetes insipidus, has developed from the surgery. And of course, keep avoiding those ICP increasing activities.
That actually leads us perfectly into the posterior pituitary issues. This is where that core concept, fluid and electrolyte balance, really goes haywire, doesn't it? We're talking ADH extremes.
Exactly. Two opposite conditions related to antidiuretic hormone. Let's start with diabetes insipidus, or DI. This is ADH deficiency. Not enough ADH, or the kidneys just aren't responding to it.
So the body can't hold on to water.
Right. It results in massive water loss, huge volumes of really dilute urine being excreted. Polyuria is the term.
How huge are we talking?
It can be unbelievable, anywhere from 4 liters up to 30 liters of urine a day. And it's practically water. The specific gravity is super low, less than 1.005. So naturally, the patient gets incredibly dehydrated. Think hypertension, tachycardia, poor skin tone, just overwhelming thirst.
And there's a really important safety warning related to diagnosing DI.
Yes, a critical action alert in the text. It says a patient you suspect has DI must not be deprived of fluids for more than 4 hours. If they're pouring out urine and can't drink enough to keep up, severe dehydration and cardiovascular collapse can happen terrifyingly fast.
Okay, crucial point. So management involves replacing the ADH, usually with desmopressin, the synthetic version. Any key safety points with that drug?
The big one is route of administration. The parenteral form, the injection, is 10 times stronger than the oral form. 10 times.
Wow, so switching from IV to PO needs a major dose adjustment.
Huge adjustment. Otherwise, you could easily cause fluid overload. And for self-management at home, daily weights are essential. If they gain more than 2.2 pounds, about 1 kilogram, in a day, that's a sign of water toxicity, retaining too much fluid, and they need to cut back the dose. Okay, now the complete opposite. SIADH. Syndrome of inappropriate antidiuretic hormone. Too much ADH this time.
Yeah.
Here, the body secretes ADH even when it doesn't need to, like when plasma osmolarity is already low. So it holds onto water inappropriately. You get fluid overload and critically dilutional hyponatremia.
Dilutional meaning the sodium level itself might be okay, but it's diluted by all that extra water.
Exactly. You have too much water for the amount of sodium present. And it's that low sodium that causes the most dangerous problems, especially neurological ones.
What kind of symptoms are we looking for? Early on, it might just be subtle GI stuff like loss of appetite or nausea. But when that sodium level really drops, say below 115 milli-UQL, that's when you see the CNS effects kick in. Lethargy, confusion, headache, and eventually seizures or coma. Clinically, they look overloaded, full, bounding pulse, maybe elevated blood pressure. And the main treatment is often really tough on the patient.
It is. Strict fluid restriction, often down to just 500 or 1,000 milliliters total in 24 hours, which is incredibly hard when you feel thirsty. We track weights very carefully again. That 2.2 pound or 1 kilo gain means they've retained about a liter of fluid.
Other medications?
Yes. Sometimes drugs called Vaptins are used, like Drivaptan or Conivaptan. They help the kidneys excrete water but hold on to sodium.
But those have a serious warning attached.
A very serious one. A black box warning. You cannot correct the sodium level too quickly with these drugs. If the sodium rises more than 12 milli-UQL in a 24-hour period, it can cause this devastating condition called central nervous system demyelination, permanent brain damage.
So they have to be given in the hospital with super close monitoring.
Absolutely. Inpatient setting only. Frequent sodium checks. And the nurse needs to constantly assess for worsening fluid overload, listening for crackles in the lungs, checking for neck vein distension, because pulmonary edema can happen really fast and is life-threatening. Also, seizure precautions are vital if sodium is very low, like below 120. Okay, shifting gears now down to the adrenal glands sitting on top of the kidneys, home of our stress hormones. Let's start with not enough function. Adrenal gland hypofunction, leading to that emergency state, Addisonian crisis. Yeah, Addisonian crisis is a true medical emergency. It happens when the body's demand for cortisol and aldosterone suddenly outstrips the supply, often triggered by stress like surgery, trauma, severe infection.
And the underlying problem?
It's really twofold. First, loss of aldosterone means the kidneys can't get rid of potassium properly, so you get hyperkalemia, high potassium. At the same time, they waste sodium and water, leading to hypernatremia, severe hypovolemia, low fluid volume, and potentially acidosis. Second, the lack of cortisol causes profound hypoglycemia, low blood sugar.
So high potassium, low sodium, low volume, low sugar, low blood pressure.
Yeah.
The patient is crashing hard. What's the immediate game plan?
The source outlines a clear sequence. Priority number 1 is volume replacement and hormones. Start rapid body infusion of normal saline, sometimes with dextrose like D5NS, to tackle the hypertension and volume loss first. Then give a high-dose IV bolus of hydrocortisone, a glucocorticoid.
Fluids and steroids immediately.
Immediately. Only after those are going do you aggressively manage the hyperkalemia, maybe with insulin and dextrose, to shift potassium into cells and treat the hypoglycemia according to protocol. The sequence matters.
And a major cause of this, especially secondary insufficiency, is something preventable, right?
Hugely preventable. A leading cause is patients abruptly stopping long-term glucocorticoid therapy, like prednisone. If you take steroids for a while, your own adrenal glands kind of go dormant. You must taper these drugs off slowly, gradually, to allow the adrenals to wake back up.
Crucial teaching. Patients with chronic insufficiency need lifelong therapy, medical alert identification, and should carry emergency supplies.
Absolutely. Lifelong HRT, medical alert bracelet or necklace, and should always have something like glucose tabs or hard candy for hypoglycemia, and an emergency kit with injectable hydrocortisone. Okay, now the other extreme, hypercortisolism, or Cushing's. Let's quickly clarify the names. Good point. Cushing's disease specifically means the cause is a pituitary tumor pumping out too much ACTH, which then tells the adrenals to make excess cortisol. Cushing's syndrome is the broader term for excess cortisol from any cause, could be an adrenal tumor, or very commonly, long-term use of high-dose glucocorticoid medications.
Got it. But regardless of the cause, the signs and symptoms of too much cortisol are pretty distinctive.
Very distinctive. The classic picture described involves fat redistribution. You get that central or truncal obesity, the characteristic buffalo hump of fat on the upper back neck area, and the very round moon face.
And the skin changes.
Yeah, the skin becomes really thin, fragile, bruises easily because the capillaries are delicate. You often see those reddish-purple stretch marks, the striae, typically on the abdomen, thighs, upper arms.
And immunity takes a big hit too, doesn't it? Massive hit. Excess cortisol suppresses the immune system, reduces lymphocytes, inhibits inflammation. So the patient is at incredibly high risk for infection, but here's the scary part. They might not show the usual signs, like fever or pus.
Exactly. They could have a severe infection brewing without a fever, without redness or pus formation. Nurses have to be hypervigilant for subtle signs of infection.
So nursing management priorities are huge here. Fluid balance must be key.
Top priority. Strict intake and output. Daily weights first thing in the morning. That daily weight is the single best indicator of fluid retention. A rapid gain means they're holding onto fluid, increasing risk for hypertension and even pulmonary edema. Sodium and fluid restriction are usually part of the plan too.
And preventing injury.
Also critical. Because the skin is so fragile, you need to use lift sheets, handle them gently, avoid adhesive tape if possible, use soft toothbrushes, and because cortisol leaches calcium from bones, they're at high risk for fractures. So, safety measures to prevent falls and encouraging a diet high in calcium and vitamin D are important. Also, risk of GI bleeding, so avoid SIADH.
Okay. And if the treatment involves removing both adrenal glands, a bilateral adrenalectomy, then they need lifelong hormone replacement, similar to Addison's.
Yes.
Absolutely essential. They'll need both glucocorticoid and mineralocorticoid replacement for life. And the teaching is crucial. Take the glucocorticoid in divided doses, usually 2/3 of the daily dose in the morning, 1/3 in the late afternoon or evening, to mimic the body's natural cortisol rhythm.
And always with food. Always with food or a snack to minimize GI upset. Never, ever skip a dose. They need to understand that and have an emergency plan, including knowing how to give themselves an emergency injection of hydrocortisone if they're sick or stressed.
Right. Okay, one last adrenal disorder, hyperaldosteronism, also called Cushing Syndrome. This one is all about aldosterone. Too much aldosterone secretion. Remember, aldosterone's main job is to make the kidneys save sodium and water and get rid of potassium and hydrogen ions.
So too much aldosterone
Means the kidneys retain excess sodium and water, leading to hypernatremia, increased blood volume, and hypertension. But they dump potassium like crazy, leading to significant hypokalemia, low potassium, and often metabolic alkalosis because they're losing hydrogen ions too.
So the big electrolyte issue here is low potassium. Management involves fixing that and maybe using a specific diuretic.
Exactly. Getting potassium levels back up is key, especially before any surgery. And often the drug spironolactone is used. It's a potassium-sparing diuretic, but it also works as an aldosterone antagonist, blocking aldosterone's effects. Which leads to a really important patient teaching point, crucial teaching point. Because spironolactone spares potassium, the patient must avoid potassium supplements and also avoid eating large amounts of high potassium foods like bananas, oranges, potatoes, spinach. Otherwise, they could easily develop dangerous hyperkalemia. Wow, we've covered a tremendous amount of ground, from pituitary highs and lows, DI and SIADH, to adrenal crises and excesses like Cushing's and Conn's.
It's a lot, but you see that common thread, right? Almost every single one of these disorders drastically impacts fluid and electrolyte balance. That's the constant challenge.
Absolutely. Whether it's the massive fluid loss in DI, the fluid overload and dilution in SIADH, the volume depletion in Addison's, or the retention in Cushing's and Conn's, it all comes back to fluids and electrolytes.
And that really dictates the nursing care. It's so focused on safety, on meticulous monitoring, especially weights, intake output, sodium levels, and really intensive patient education about managing lifelong hormone therapy, recognizing warning signs, and knowing what to do in an emergency.
Which brings us to maybe a final thought, something that touches on the psychosocial side. We talked about some of the physical changes these conditions cause, the permanent bone changes in acromegaly or the moon face in striae and Cushing's. These are visible, sometimes profound changes to someone's appearance and body image.
They really are. And treatment might stabilize the condition, but it doesn't always reverse those physical alterations completely.
So thinking about that, when treatment can only partially fix these very visible, sometimes distressing physical changes, how can we, as nurses, best support patients and their families dealing with that, coping with a body that feels and looks fundamentally different, maybe permanently?
That's such an important point. It requires us to look beyond the labs and the hormone levels. It means acknowledging the grief, the potential loss of self-image, providing emotional support, connecting them with resources, maybe support groups, and just creating space for them to talk about how these changes affect them. That's a huge part of holistic nursing care. It's not just about the meds.
A powerful reminder to always consider the whole person, especially when dealing with chronic, life-altering conditions like these. Thank you so much for breaking down this really complex chapter with us. My pleasure. It was a good discussion. And from the whole Last Minute Lecture team, thank you, our listeners, for joining us on this deep dive.